Welcome everybody to today's webinar on unilateral biportal endoscopy. We will give a few seconds for everybody to join before we get started.
Welcome here from Germany, Karlsruhe, joimax company here at the ESPINEA training center, training and education center. And we checked already our presentations, our faculty presenters and surgeons are already online. They're waiting for you to join in. My name is Wolfgang Ries. Next to me is Clemens Barthold. He's head of product management.
Nice to meet you all.
From my side, I'm the founder and CEO of joimax, but also ESPINEA, our academy. We have a
great group of faculties here with us today.
Yeah, great group of faculties from Korea, from Mexico, and from Germany, all over the world. We're spanning the globe, and different time zones. For your information, also for the audience, not everybody's in yet, but we have about 500 registrants for this webinar, close to 500.
Big one, yes.
It's a very big webinar. The interest is really big. That's very impressive. Thanks for everybody. Thanks for everybody listening. Our faculty surgeons became a little bit nervous when they hit the number. Of course, their interest is really good. It's great. And right on. Having said enough, I want to introduce quickly again our audience. This is Professor Woo-Keun Kwon from Korean University in Seoul, and it's a pleasure to have you. And for him, it's 8 p.m. already. He had dinner after a long surgery day. Then the next presenter is Javier Quillo from Mexico, early in the morning, having had his first coffee, 5 o'clock there. Nice to have you, Javier. And in Germany, lunchtime, Raed Abohussein up in Gütersloh, and these three gentlemen give you the insights about endoscopic spine surgery, but focus specifically on UB, unilateral biportal endoscopic spinal surgery. That's the topic of today. And we're going to give you a quick intro. We're going to give you just now a quick intro from a company side, how we see endoscopy really moving and how we are developing and going into this direction. As you know, most of people who are familiar with us know that we are not just offering a biportal system since about 1.5 years. We started out really in 2001 with a transfemoral technique. We are well known for that. And this graphic should show you that we are covering now with about 16 different systems, the whole spinal column, from transfemoral, from interlaminar, cervical. We do pain therapy, we do decompression, deherniations, and also moving into endoscopic assisted fusion or endoscopic fusion. So we are offering 3 columns of therapy for the spine, everything endoscopic based, and we have the complete electronic equipment to that as well. And as I said, we looked mainly in the beginning at uniportal. We went back and forth, should we do biportal, yes or no? I had the occasion to meet Sang Ho Lee 2008 already. We discussed it in and out, and biportal, should we do it or not? He was very skeptical. It started out in Korea really with biportal. And some of our faculties, or Javier, for example, he got trained also in Korea. Professor Kwon in Korea started out with it. And Raed Abohussein also here in Germany, but also in other places. But we decided also 2 years ago we need to offer that. If you, next slide. So we are well known for our transfemoral techniques in all kinds of areas, the standard set, the XT set for BMI beyond 30-35, and TransSCP just launched 2 years ago, a very special instrument set, specifically tailored for endoscopic fusion also, gives you a bigger working channel. And we have developed together with the Korean group, with Woo-Keun, the thorax system, the thesis thorax, which they really had been conquering as endoscopic-based system for the decompression on the spine. Interlaminar, we started out with our standard interlaminar system, then the Pro which is a little bit extended system with a wider working channel. The Delta is our workhorse for major decompressions. The Delta system is a 6 millimeter working channel, a very big endoscope. And finally, as we call it here, new, we also launched a biportal system. We feel as a leading company in this field obligated to offer the whole range of endoscopy, not just uniportal and only biportal. We're offering everything, and we think if you want to consider yourself and you want to become familiar with endoscopy in spine, you need to be offering all best systems for any indication, the right tool. Next slide. And this goes together also with this nomenclature consensus paper driven by Chris Hofstetter in Seattle. And together with a group of 27 surgeons, he published this paper, giving all the different systems a nomenclature for cervical, for thoracic, for lumbar, but also for endoscopic assisted surgeries. And here UBE is listed. Probably this needs to be updated because UBE is merging far much wider than just into endoscopic assisted surgery. It can be done also, but overall for other applications and indications. But overall, more the consensus is UBE has a place in endoscopy in the range of about 20-25% of all applications if somebody is fully trained. And the three gentlemen presenting today give their opinion how they use UBE compared to uniportal, biportal, when and where they apply it, when they use it. And it's not just one system against the other. We are far beyond that. We are discussing really when is the right indication for this system, a transforaminal, interlaminar, or biportal system. Where is the right indication for it? Having said that, that's how we train also in our program under ESPINEA, our different systems for beginners, for having passed the beginning level to the competent level, then advanced level. There we start training. If somebody has a lot of experience or have some experience endoscopic already, then they jump earlier maybe to biportal. But if somebody is completely new, we just don't see it's a good idea to jump immediately to biportal technique. That's the reason why we include it in our program, but we always train biportal also in our courses, and then you can move up all the different levels. This program is accredited by the Royal College of Surgeons of Edinburgh, and we have the honor that a key member of our academy who helped us to set up this program, Alistair Gibson, is also online listening to this. Welcome for him and being part of this session also. Next slide. That's it from our side. We just wanted to give you a quick intro how we see endoscopy heading, and we are happy to listen to Professor Kwon. Kwon, if you would start your presentation, would be great.
Thank you very much in the meantime for this introduction. And I believe the most pressing question to many out there is this comparison, when to use monoportal, when to use biportal, and especially for which indications. And this is exactly what Professor Kwon is going to tell us about, because he is very experienced in both, started out in biportal mostly, migrated into monoportal, and now is an expert in both. So I'm looking forward. Professor Kwon, the stage is all yours.
Thank you very much. It's a great pleasure to have this opportunity. Today, I would like to talk about uniportal versus biportal and talk about the indications, talk a little bit about the techniques, and have a chance to look into the current evidence that we have. So let's start with a brief introduction. I understand that there are a lot of participants at different levels, but basically, I believe that most of you might know what uniportal is and what biportal is. In uniportal, we definitely have transforaminal, we have interlaminar, and in biportal, we do the major procedure through these two different portals. So briefly, transforaminal is the most traditional, most classic way to reach into the spinal canal. We get there inside through the Cambridge triangle and reach the foraminal area at the beginning. And to say about uniportal interlaminar approach, we can get to different pathologies, not only the lumbar spine, but also the thoracic spine and cervical spine. And we are utilizing this technique in so many different pathologies these days. To say about biportal surgery, we call it UBE, the unilateral biportal endoscopic surgery. And we all know that how much this technique is emerging and how many things we can do with this procedure as well. I don't want to talk too much about the detailed techniques because we have a lot more to talk about comparing these two techniques and finding the best indication for both of them. To start, let's look into the existing literature, which are comparing uniportal and biportal. These two studies, they're both meta-analysis, and in this presentation, I tried to only include high-quality, high-evidence studies like meta-analyses or nicely designed prospective studies. In these two meta-analyses, they compared lumbar-degenerative diseases when they were treated with uniportal and biportal. And these two studies reported that uniportal was somehow related with shorter OR time and a shorter hospital stay. But importantly, when they were compared these two techniques, clinically, they were not that different. In this study reported in World Neurosurgery, they compare uniportal versus biportal for discectomy procedures. And similarly, they reported that uniportal was related with shorter OR time. But interestingly, biportal reported a lower recurrence, and it was similar when it was compared with interlaminar or transforaminal uniportal procedures. Once again, clinically and radiologically, they were not that different. This is a new study which is reported from Korea, from my colleagues. And this study compared ULBD for spinal stenosis, and it compared open versus uniportal versus biportal procedures. And they reported that clinically, uniportal and biportal were both equivalently superior to open surgery in terms of post-op VAS scores or inflammatory markers or post-op muscle injuries. However, when they compared uniportal versus biportal, they didn't find any significant differences. Another two meta-analysis and a prospective study comparing ULBD for spinal stenosis, they reported quite a mixed results. But once again, if we look into the details, they're kind of reporting that there are not really big differences in terms of clinical, radiologic, or complications related to the surgery. And this meta-analysis reported in European Spine Journal, it once again reported that uniportal has some relation with shorter OR time, but otherwise not really different in terms of clinical outcomes. So if we summarize this, it seems like uniportal is reporting a bit shorter OR time compared to biportal, and based on its characteristics, it has a smaller incision. However, biportal seems to have a little bit of lower recurrence. But interestingly, the results are very, very affected by the reporting group. And I think that means that there's no really significant superiority of each techniques on each other. This final one is a report meta-analysis on cervical surgery, and it just shows a similar result. So if we look into the existing literature, it seems like overall, the scientific evidence says there's no big differences between these two techniques. So does that mean that they are really the same? I would like to look into some more details, which we cannot see in the literature. I wanted to look into the characteristics and look into the real advantages of each different techniques. If we look into the review articles coming out, most of them conclude that it's just up to your technique, it's just up to your preference, and they're not that different. What I really wanted to do in this presentation is that I wanted to explore the unique characteristics of two different techniques and harness the strengths of them, each of them, and achieve optimal outcomes from two different surgeries. So let's have a look into some of the characteristics of these two different procedures. In uniportal surgery, it's very similar to microscopic surgery. You look into the surgical field through a visualizing corridor, and the instruments come in through that corridor into the same angle. But in biportal surgery, you look into a certain angle and your working instruments come from a different angle, giving you a little bit of different angles at the tip. And it's really important to make a nice triangulation to get at the target point in biportal surgery. It's not only about the visualization, it's also about utilizing the instruments and the drills. So in uniportal surgery, you need to remember that the camera, the vision, is always at the same angle with your instruments. But on the other hand, in biportal surgery, your vision and your working instruments, there's a little bit of difference between the two angles. Then what difference does these bring? There are some certain technical differences in uniportal and biportal, especially in terms of utilizing the drills or the instruments. In uniportal surgery, because it's a single axis surgery and you look into and work inside the same angle, you can see on the video, the camera and the instrument always work together, move together at the same angle. And basically your left hand, which is holding the camera, does most of the work. The advantage of this is that because you hold this with your two hands, it gives you a really firm and stable holding of the instruments and really helps you when you're doing something important on a really fragile area inside there. On the other hand, when you do a biportal surgery, your right hand does most of the work. When you look into the video, your camera can be staying at a certain point, and your instruments can be moving in, out, around different areas while keeping your vision at a stable point. It means that you're looking into it with your left hand, but your right hand does most of the work. So because if you were a right-handed surgeon, you can do a very precise working with your drills, your instruments, just like when you're drawing something or writing something. But sometimes because it is floated up there, you need to understand it could be unstable, and you need to keep that in mind and be careful. Now let's look into the advantages of uniportal over biportal. Don't be upset. I'm going to talk about some of the advantage of biportals after this. So let's start with uniportal. At least one portal less invasive. You do have a single portal, and in biportal, you have a two portal system. So it is one portal less invasive. And because you always have a view into the working channel, I think you can easily coagulate everything, even on the way out. So I don't put a drain when I do a uniportal procedure, but when I do a biportal procedure, you can look into the working corridor. So I put a drain to just make it extra safe in terms of bleeding control. Another big advantage of uniportal over biportal is if you utilize the CE arm and find a right corridor through the interlaminar window and reaching to the target area, you can minimize the amount of bone work getting inside there as you use the natural interlaminar window there. When you do a biportal procedure, you need to make another additional corridor for your working channel, so there's inevitably a little bit more laminotomy compared to uniportal surgery. The biggest advantage of uniportal is the unique transforaminal approach itself. If we remember where endoscopic spine surgery came from, it's still transforaminal. So for transforaminal is the least invasive way to reach into the spinal canal. It's a single portal. It's get through the muscles, not cutting the muscles. So there's minimal damage to normal structure surrounding it. So if there's a foraminal pathology in the lumbar spine, reaching there inside there through the transforaminal approach is a very, very minimal invasive way. And if we remember the natural anatomy of the spine, if we go to the upper segments of the lumbar spine, the foramen gets larger. On the other hand, if we go to the upper segment of the lumbar spine, the interlamina gets smaller. So if we're reaching their interlamina, you inevitably have to do some more laminotomy there. But if you reach there inside through this wide, naturally big transforaminal area, it's very, very less invasive. So especially for this upper segment of the lumbar spine, it's really a best way to reach inside there. The best that I think is that when we're reaching a thoracic disc herniation, we don't need to do this massive bone removal, what we used to do in open surgery. We can just simply reach there with a transforaminal approach through a less than a centimeter approach, and is one of the best indications for thoracic disc herniations. The last but not the least Uniportal surgery has a big advantage in terms of water dynamics because in biportal surgery, the water input comes in and comes out through two different channels. It's really extremely important to have a really nice preserved outflow there. Otherwise, it can end up with a catastrophic outcome related with water pressure problems. But on the other hand, in uniportal surgery, because the water comes in and out through a single channel, single tube, it's relatively safer because you have simultaneous in and out of the water flow. So it's known to be relatively safer in terms of water pressure. So when you do a biportal surgery, you need to utilize the outflow all the times, sometimes by utilizing semitubular retractor or optional valve systems to keep the water pressure below a certain level to have safety all the time. So now let's move on to biportal surgery. When we compare these two different techniques, uniportal and biportal, in terms of surgeon ergonomics, there's no way uniportal can beat biportal. Especially at the early stage of your learning curve, it's really hard to utilize the uniportal system. And sometimes when you do a multi-level system surgery and do the procedure for like 2 or 3 hours, it really gets exhausted when you have your shoulder up like this throughout all the procedure. So in these certain cases, it's really good to have this better ergonomics when you use a biportal system. Another big advantage is when you do a uniportal surgery, you always need to stay inside the working tubula channel. And once you pull this out, your muscle will just come into your view and block everything from being seen. However, when you do a biportal surgery, simply by sliding out the scope a little bit, you can have a much wider view of the surgical anatomy, especially really, really helpful in your early stage of learning curve. This is the best thing that I love about biportal surgery. It's not a all everyday indication, but in some certain cases, then you need to go to the contralateral side and explore both the exiting route and the traversing route. It's really more easily accessed by biportal system. When you do a uniportal system, the pivot is basically on the lamina. So if you wish to move on to the other side of the contralateral, you need to do a additional laminotomy to get inside there, or it's really hard to reach the other side through a single angle. But when you do a biportal surgery, the pivot is basically on the skin, so you can keep your camera on a certain point, and your instruments can easily come to this side and the other side, all the way from the caudal to the cranial side of the contralateral canal, which makes it much easier to observe and decompress and do something on the exiting route and the traversing route at the same time. The biggest unbeatable advantage of biportal is uniportal systems need to have their own dedicated system to do a certain procedure, but in biportal, you can have these dedicated systems, plus you can bring any of your open instruments at any time, and it gives you a really larger freedom of equipment use, which is a great benefit in many cases. Finally, I would like to wrap it up by saying how I utilize them. I think it's not right to say there is a certain indication for both procedures. The scientific evidence says no difference, and they work differently on different hands. I think both techniques deliver equally good outcomes in the hands of an expert. As I said earlier, I predominantly do a lot of full endoscopy, uniportal more than biportal. But what I want to do here is leverage the strength of each techniques to their fullest advantage and tailor the utilization following the needs of each cases and take advantage of having both in my hands. So this is how I do them. For foraminal, extraforaminal, or upper level lumbar discs, it's always transforaminal uniportal for me. And for single level or 2-level ULBD for spinal stenosis, I think it's a great advantage to do them with a uniportal interlaminar procedure. However, in certain cases, when I need to see the contralateral side, exiting and traversing routes, I prefer biportal. And in multi-level cases, which would take me like 2 hours or 3 hours in a certain surgery, I definitely prefer doing a biportal procedure because it's much better at ergonomics for the surgeon. For cervical, thoracic interlamina, I never want to get encountered into any pressure problems, so my choice is uniportal. And thoracic transforaminal is just the best indication for transforaminal. And for some complex scenarios where I need to utilize different various instruments, then biportal would be my choice. To summarize, these two techniques are similar but distinctly different, and they can just treat a lot of different things under the expert hands, both equivalently good in terms of clinical and radiologic outcome. I think we should consider the characteristics and advantages of each techniques, and also consider your own clinical setting when you're choosing your technique of choice. And I would like to conclude by saying that the best would be having both in your hands and taking advantage of both of them. Thank you very much.
Thank you, Professor Kwon. Excellent. Great presentation. Thank you.
Thank you very much. Yes. In the meantime, if there's any questions from the audience, don't hesitate to put them to the Q&A section at the bottom of the screen. We can answer 1 or 2 questions now if you have some, or you post them and we will try to do a question session at the end of the webinar.
Professor Kwon, if you one question from my side. If you do fusions, assisted fusions, what is your preferred choice? I mean, it's at the end of the presentation, Raed Abohussein is talking about it, but I'm curious to know what is your choice for that, okay?
I currently do biportal fusions. The reason that I do it biportal is because I always want to keep an eye on my procedures. In uniportal surgery, there's a very short single blind spot when you need to rely on the fluoroscope. And at this point, I don't want to keep that as a blind spot. So I do biportal procedure for fusions. But I do agree with the advantages of uniportal fusions as well. So at some point, I would love to have a chance to have a talk about uniportal versus biportal fusion techniques at some time. Yeah.
We heard about the advantages of biportal for the contralateral side, especially. So how do you deal with ipsilateral working, as this can be a bit more challenging, right?
If it's just about the ipsilateral side, I prefer uniportal. But the contralateral side is when I'm doing both sides. When I work on the ipsilateral side and then move on to the contralateral side, then I think biportal has advantage in reaching on the cranial end and the caudal end at the same time.
Good. So maybe 2 very quick questions from the audience as well. Hugo Alexio says, very interesting presentation. Which one would you choose for a single level simple disc herniation?
For a single level simple lumbar disc herniation, it's always transforaminal for me. I think it minimizes the amount of bone work and minimizes the injury to the surrounding structures. So unless it's a very complicated narrow 5S1 case, most of my lumbar cases are transforaminal, uniportal. Yeah.
Thank you. And Hanging Lim is wondering about the biportal transforaminal approach, especially L5S1, if that's easy to do or not. So you said transforaminal, you would always choose monoportal, right? Or what is your opinion on this?
Yes. It once again is my personal preference, but I prefer uniportal and transforaminal approaches. Biportal is of course doable, but I think when you do it biportal, it's very similar to a paraspinal Wills approach, rather than doing a real via transforaminal approach. So personally, it's uniportal for me, but I do agree it is very much doable as well with biportal.
Okay.
For time constraints, I think we need to move on. We don't want to hold the other questions, but we
can save them for later. There's more experts coming that can tell us about their experience, especially Dr. Javier Quillo. We're looking forward to your presentation now, and we will answer the remaining questions later.
Okay, thank you very much. Congrats, Dr. Kwon, for his great presentation. Let me share my screen. Could you see my screen?
Yes, we see.
Okay. Today, let me share with you some key concepts of the evolution of biportal endoscopy in the last years and some experience with some lumbar cases. First of all, thank you so much for this kind invitation to share my experience regarding biportal endoscopy. However, I'm agree with Professor Kwon regarding the use of both techniques. I believe that it's could be a better comparison if the surgeon know both techniques and know how to use both techniques. So in my practice also, I believe in all the full spectrum of endoscopy. However, in terms of regarding biportal endoscopy, this timeline exemplify the evolution of biportal endoscopy in the last years, since the 90s, for example, when the technique was introduced in Argentina by Dr. Julio D'Antoni. You can see very interesting points at this step, because, you know, these were all the contraindications for use biportal endoscopy. Any spinal stenosis, infections, tumors, revision surgery, cervical and thoracic indications at that time were contraindications, because was the introduce of the technique. However, after the 20s, in 2022, Dr. Said Osman published the first papers regarding outcomes with biportal endoscopy. But at that time also, the technique was very old, with the use of common surgical tools. And after that, in South Korea, Professor Ho introduced more advances in technique. For example, the use of the technique for lumbar spinal stenosis. And he published the first paper in 2016 regarding biportal endoscopic decompression for lumbar spinal stenosis. That was the early application of the technique. However, after that, some key spine leaders in biportal endoscopy starting to publish more evidence regarding indications of biportal endoscopy, and they expanded these indications. And now we have the broad spectrum of indications to employ biportal endoscopy in degenerative spinal diseases. And not only for that, we have different indications. For example, how to perform procedures intradurally, or we are starting with anecdotic techniques for tumor removals, and also for revision or assistance surgery. And what can I say regarding cervical, thoracic, or fusion surgery, which are now indications for biportal endoscopy. But it's very difficult to compare biportal endoscopy with transforaminal uniportal endoscopy. There is no comparison. There is no point of comparison, because there are completely different techniques. So that's the reason that not all the spinal regions able for perform biportal endoscopy accomplish the same indications that uniportal endoscopy. And also depends on different variables, as Professor Kwon said in his talk. But also we need to highlight the preference of the surgeon, because not all surgeons are able, or they have all the variables to employ very well uniportal endoscopy. So biportal endoscopy still has another option for water-based endoscopy to accomplish these difficult or these other indications. However, now we have in the period of adaptation and development, because more brands like joimax are launched the different and specific and very specific systems for use biportal endoscopy currently. And now we have different textbooks on more evidence regarding biportal endoscopy. And now we can use this technique correctly and expect more for this technique. However, what are the clinical advantages regarding biportal endoscopy over uniportal endoscopy? Maybe in the basic advantages, when we compare both techniques, there is no one winner for these advantages. For example, when we compare the high quality visualization between both techniques, you can observe these 4 videos. So the first one is obviously tubular microscopic decompression. However, the third and fourth videos compare the high-quality visualization between uniportal endoscopy, interlaminar approach, and biportal endoscopy, a common ULBT. So there is no big difference between both techniques because both are working in a water-based environment. So also another myth regarding biportal endoscopy is the tissue damage. But when you perform both techniques, you know how to use the dilators to approach with uniportal endoscopy, the interlaminar window. This slide exemplifies the tissue damage observed in biportal endoscopy. The superior panel is the preoperative MRI in 3 different patients with lumbar spinal stenosis, 3 different lumbar spinal stenosis, centrally, subarticular, and subarticular. And you can see, you can observe in the inferior panel the immediately postoperative MRI and the muscle edema after the surgery. And you can observe that the first 2 patients were operated with biportal endoscopic technique. And also, the third one was operated under uniportal endoscopy interlaminar decompression. You can see more postoperative edema in the multifidus area, which is not clinically congruent because the patient after the surgery, he doesn't have pain. But the point is that how you employ, how you perform correctly the technique, how you be gently with the tissues, you can expect the damage in these tissues, obviously. And you can see the muscle in the biportal after the biportal endoscopic surgery in these 2 patients. And you don't observe more edema than uniportal endoscopy. But why I had edema in this 3rd patient? Because I use a stethoscope, a delta stethoscope, the bigger endoscope for decompress this patient. But it's not congruent clinically. However, this is a myth regarding biportal endoscopy. If you perform the technique, you cannot expect a big damage in the soft tissues after your surgery. This is the common steps after the surgery in biportal endoscopy, which is not different compared with uniportal endoscopy. So the myth of perform shorter skin damage in the patient is not true regarding biportal endoscopy. This is a typical paramedian approach in biportal endoscopy. You are using the same dilators that uniportal endoscopy, and you can use working cannulas to protect the soft tissues, and also you can use self-retracted cannulas for the endoscope to protect the soft tissue around the endoscope. So you are protecting the tissue and you don't need to perform an extra cavity as a lot of surgeons know or said about biportal endoscopy. You respect the plan similar to uniportal endoscopy. The only difference is that first one, you are not working through a single channel or an unrestricted trajectory. And the second one is that you are not working limited by a working cannula, because these 2 working cannulas are used in the endoscope and through the surgical channel. So that's the reason that your surgical fields is expanded, and you can introduce the endoscope by a single pivot in the skin, but you can introduce in the surgical field your working tool by different angles. This is a typical paramedian approach, and this is the approach that I recommend for beginners for starting in biportal endoscopy, because with this approach, you can explore a lot of diseases that are occurred in the interlaminar window. So you can know first, this is your first step to know about biportal endoscopy. This is the most important approach to know how to explore the interlaminar window. Yes, there are some differences between the site of you are working, which is not occurring in uniportal endoscopy. It doesn't matter which is the site that you are working in uniportal endoscopy. However, in biportal endoscopy, this could be a difference between uniportal endoscopy, which is overcome during your experience and learning process. In the left side, for a right-handed surgeon, it's very easy to approach the interlaminar window. However, for the right side, you can go for the interlaminar window a little bit down compared to the left side, but this at the end is the same approach. There is no big differences also. The steps for the bone removal are completely similar to microsurgery or to uniportal endoscopy, especially for the last one, because remember that you are working under a water environment, so you can identify and take advantage of this technique by identifying the surgical landmarks and perform circumferentially the decompression, which is very, very advantageous for contralateral decompression, as was mentioned before, because you can identify immediately and directly in front of you the surgical landmarks and decrease the undercutting of the contralateral side. However, the point is the ipsilateral decompression. And it's very easy because obviously you are guided by the anatomy. So this is an anatomical guided approach, biportal endoscopy. So when you stop your ipsilateral decompression, first one, there is different landmarks. For example, when you have free mobilization of your traversing nerve, for example, in this slide, you can observe the ipsilateral decompression. And when you have free mobilization of your traversing nerve, or when you have identified the base of the SIP, the medial aspect of the SIP in its base, and you can stop the decompression to avoid the damage of the ipsilateral facet joint. So you are guided by the anatomy. That's the reason that biportal endoscopy still is a minimally invasive option under water environment, similar to uniportal endoscopy. The contralateral decompression obviously is guided also by the anatomy, because you cross the midline under the contralateral lamina and decrease the undercutting of the bone element. So the most important thing is to perform a proper ipsilateral laminotomy, not laminectomy, and then cross the midline and identify the bone landmarks until reach step by step the ligamentum flavum in an over-the-top technique, and then decompress the neural elements to perform a good decompression. This is a common process through the fluoroscope, only for educational purposes, to demonstrate how the surgeon pass to the contralateral side in this kind of procedures. And as I told you, finally, after identify the neural element free and identify the medial wall of the pedicule, all these landmarks guide you to stop your contralateral decompression. This is another example of biportal endoscopy. This is part of our experience when we decompress contralaterally. And you can see this patient with this left-sided L4, L5 synovial cyst, and how you can perform this contralateral decompression of the traversing nerve very easy with a lot of shape. This is obviously an unstable technique until the surgeon gain experience, because there is a lot of tips to maintain stable triangulation during your surgery to avoid damage of your neural tissues. This is another case regarding discernation, but a highly migrated discernation at L4, L5S1. And you can see the discernation is above in the hidden zone. And this is the postoperative MRI compared with the preoperative MRI. The subarticular area was very good decompression with the minimal damage for the facet joint and the lamina. This is part of the intraoperative video, and you can see that in this approach, we only detach the ligamentum flavum similar to a microsurgery, but with an endoscopic technique. And finally, you can explore this subarticular area until reach the migrated fragments and explore even the proximal foraminal area. This is the exiting nerve root. And finally, you can confirm a good decompression. This is the posterior wall of the the vertebra at L5 and observe the traversing nerve, the S1 nerve free. This is another case that we use biportal endoscopy. This is a revision case, a patient with interspinous device at L5S1 and foraminal stenosis, proximal foraminal stenosis with this, in this patient with the revision was aimed to decompress the exciting nerve. And you can see after the decompression and observe directly nerve free, here is the pedicle, and this is the foraminal area, and this is the postoperative MRI compared with the preoperative MRI. We don't need to remove the or cause more aggression that the surgery previously caused. And you can see the postoperative MRI, the good decompression of the tip of the SIP only. This is another case of revision surgery in a patient that was operated and with transfacetal screws at L5S1. And you can see the video, this preparative video, how the right side at S1 screw cross the midline, and there's a bridge compressing the S1 nerve. The patient had radiculopathy, and after the decompression, the nerve was free. However, how we perform the decompression, not only directly, we can use the endoscopy, biportal endoscopy as an assistant tool. So you can perform less aggressive technique to accomplish the goals that the disease are required. And then you can use this technique to guide your approach and complete these goals. We use this technique to remove the implant, to assist the implant removal. And finally, we decompress ipsilaterally, only ipsilaterally, the nerve to check that nerve was free, not damaged by the screw removal, and observe the integrity of the S1 traversing nerve. And this is another case of revision surgery for an ASD at L2, L3. You can see this patient was operated, but the patient only feels radiculopathy, symptomatic radiculopathy on the left side at L2, L3 because has severe stenosis. The problem was that the patient had some implants that can hidden or can block the trajectory for a transforaminal decompression. So we decide to use biportal endoscopy, and after that we increase the foraminal area by removing only the tip of the SIP. So the patient had this material, this postoperative material in the foramen. So we decide to go with biportal endoscopy to accomplish the goals of the surgery in a shorter time and in a more easy way. So after that, you can see that the procedure is a common foraminotomy after identify the exciting nerve and the traversing nerves, and that was accomplished with biportal endoscopy, similar to uniportal endoscopy. So my conclusion regarding the experience of biportal endoscopy gained in the last years, is unilateral biportal endoscopy a target-oriented procedure? Yes, this is a target-oriented procedure. It's a set of highly targeted addressed approach with all the minimal invasive related advantages. So we need to take advantage of this technique for different indications in this spine. Is unilateral biportal endoscopy the same as full endoscopy? Obviously not. This is not the same procedure. This is another option for weather-based in spinal endoscopy, but it has pros, cons, and drawbacks, and the surgeon needs to know very well this technique. And what does biportal endoscopy success depend on? It depends on its correct technical application. The experience, this is a variable that is very different between surgeons. So each surgeon can say about his experience and about how he used biportal endoscopy, but the correct application of the technique warrants that the successful outcome after the technique. That's the reason that we need to highlight good learning programs for this technique. Thank you so much for your time.
Thank you very much.
Thank you, Dr. Quillo. Javier, nice presentation and good overview. Just for the curiosity, because of time constraints, we need to move on, and I would like to have the questions asked after the last presentation. Just one question. Nowadays, you started this biportal, you do use also uniportal. What's about the average of you using biportal and monoportal right now?
In my practice, maybe I use biportal endoscopy and uniportal endoscopy in a 50% and 50%. Yeah.
Okay. Half, basically.
And very quickly, which optic angle do you use? You prefer in biportal?
30 degrees endoscope, because it's very easy to use this lens angulation, because I have experience with uniportal endoscopy. And this kind of angulation allows me observe very well the surgical field.
So as you know, we offer all three angulations, 0, 15, and 30. So 0 is often preferred by beginners because the straight view is easier for orientation. But then as you get proficient, you will find it easier to go around the corner. So you go up to 30 even as your preferred choice.
Agree.
We offer all three angles, 0, 13, 0, 15, and 30 degree. Okay. Yeah.
All right.
All right.
Then, Dr. Abohussein, we are looking forward to your talk on assisted fusion in biportal. And we'll afterwards do the final question round here.
Thank you, Clemens. Thank you, Wolfgang, for the invitation to be with you today to share my experience. And thank you, Dr. Quillo and Dr. Kwon, for sharing your great experience with us today. Could you see my screen now, the right one?
We can see the presenter's view, so it is actually the second screen that you're sharing.
No, it's good.
Okay.
That's okay.
It's okay now.
It's okay now? Okay. When we talk about and UBE, unilateral biportal endoscopy, or we talk about the difference from uniportal to biportal, in my opinion, we need to have both of them. Clemens, it's the right screen now for you?
That's okay. We can see it, yes.
Okay, the uniportal or biportal, so in my opinion, we need to have both of them as endoscopic spine surgeon. Today, I should talk about endoscopic assisted fusion or endoscopic fusion. Before I talk specific about the advantage of and the role of endoscopy in fusion surgery, we should ask ourselves what's challenges of all kind of fusion. So we would like by our fusion surgery to achieve a solid fusion, to do the compression of neural elements, and to take care of lordosis on the global spine balance. And if we could, if we can do this achievement in a minimal invasive surgery, where we save and preserve the posterior structure and the paraspinal muscles, we have a good advantage. So in how can the endoscopy, uniportal or biportal, help us to have a solid fusion? The first of all, to get a solid fusion, the first step is to do a good end plate preparation. As you see in this video, to do a good end plate preparation is to remove the cartilage end plate, but to keep and preserve the bony end plate. And when discectomy, good end plate preparation, you have enough place to have a good enough footprint for your implantat. But to bring the cage inside, you need to have a corridor, a safe corridor to go. And this is a campaign or a transforaminal or campaign triangle, as all of us know it. So in this video, I show you how after endoscopic facetectomy, we can get enough place, enough corridor to insert our cage in the disc space safely. As we see here, this is a campaign triangle between 12 is dura or and 6 is lateral. And when we have a good place to insert our implantat, we need to do a good release to have a good lordosis. So this endoscopy can enable us to do what's very challenging to do it in open surgery or to do it with minimal invasive surgery, is to go inside the disc space, do good discectomy, to go anterior, to do anterior release of the anterior longitudinal ligament on the anterior annulus. As you see in this video, I have done discectomy, end plate preparations to the anterior annulus to do the release of the anterior longitudinal ligament under direct vision of endoscope. And then then the question is, when we have a good place to put the implantat, what would you choose, to put a small cage or a big cage, one cage or double cage? We should ask ourselves, in fusion surgery, all kinds of fusion surgery, we have to take care of what's called stress. Stress equal force on the area. This means when we have high forces, we need to increase our footprint. So it means by higher force like restoring height, obesity, correction of spondylolisthesis, we need to increase our footprint. Also, the location of cage. Does the location of cage matter? To put the cage anterior, posterior, in the middle? Yes. To put the cage anterior on the apophyseal ring, where you have a good bone density, is good to have less risk of subsidence. And also to put the cage anterior, you can get a better lordosis. So endoscopy can help us to place our cage, to insert it, to safely, and to place it. To place it anterior, to place one cage, double cage, to place a big cage, or even to break the boundaries and make the revolution, and to place a real X-leaf or olive cage from posterior. When I talked now about how the endoscope can enable us to do the job better than in my hands to do it open surgery or in minimal invasive surgery. So, but which technique we have in endoscopic surgery? When we talk about it today, we talk specifically about unilateral biportal techniques in fusion, but I must mention here my most favorite technique and most minimal invasive technique, and this is the monoportal transforaminal or transcambine or trans-SAP monoportal over the wire technique, endolift technique. And this is the first thing I ask myself. I cannot do it in endolift technique over the wire technique, so I do it for my patient when I need to do facetectomy, or to do direct decompression of the canal. So I use to do facet resection technique. What I mean with facet resection technique is the unilateral biportal or the monoportal PLIF, and I don't prefer it. The second one is unilateral biportal UBA TLIF with one cage, double cage, large cage. We will show this, or what I call posterior OLIF. So the steps of unilateral biportal TLIF. It's like what we have in conventional TLIF. We do, as first thing, we do facetectomy, ipsilateral or bilateral. When we do endoscopic facetectomy, we can use the high-speed pair. Also, we can use the osteotome to gain and get autogene graft for our fusion, as you see in this video. And then we go to annulotomy, end plate preparation, cage insertion. When you have enough place, we can and put pony material, and then decompression, flavectomy at the end, percutaneous screws. When we talk about, in the next slides, I'd like to show some cases of unilateral biportal TLIF. As we see here, this endolift cage from joimax in UBE technique. I put it from posterior, but I can rotate it under direct vision and place it really on the anterior epiphyseal ring. And in this video, I show how to do it. For example, here I insert the cage. His cranial, there is the exiting nerve is here protected, and we have safe corridor through transcambine triangle. In this video, this is first cage in place. I rotate it, put it more to the anterior side. As you see, when you do a good decompression, a good discectomy, you have enough place to put bone materials, calcium phosphate, or your the graft what you gain from the fasciectomy and the laminectomy, and then also to put the second, to put a second cage. And now you can choose to put a smaller cage from height to gain a little bit more lordosis. You can also do it. So here's the exiting nerve. Here's the exiting nerve. Here's the annulotomy side, the safe corridor through campaign triangle. And I insert now the second cage. I'll make it a little more. Okay. And here we see the double cage, 2 titan cages inside the disc space, exiting root, and we start to do the decompression. So in this technique, for example, is an extra flavum technique. You have the flavum to protect your neural elements or your dura till the end of the operation. Then I start to do the decompression. Actually, it's case specific what you do first. About one of the nice things to do with endoscope, you don't put the screw first and expand on the screw like in minimal invasive TLIF, so you can go directly inside the disc space and keep the flavum till the end. And you see here we did discectomy, put 2 cages and do on the direct vision, direct decompression over the top to till the contralateral facet joint. If you need, you can do also fasciectomy by its sides. Here again is the 2 cages through camping, going outside from the disc space. I will make it a little bit faster for time here. Exiting root. Here's the dura over the top. And here's X-rays. As you see, 2 cages. The patient 2 hours after the operation. Okay, he can 2 hours after the operation, no opioid, and very small. This is the smallest one. This is the same one what you have for the same incision what you have for your percutaneous screws. And here is 8 months control, and we see the cage is fused. Another case, 5S1, when we needed to have a big footprint, double cage, small incision, patient is happy. Another case of double cage. And here, the posterior unilateral biportal posterior olive, and very, very noise technique that I mean with olive here, that I mean a real olive cage, 18 millimeter width. And here you see I put the cage from posterior, rotate it, in the same time we could do direct decompression. This is a cage in place. You do the direct decompression from posterior. And especially in cases when you have to put a big cage because of bony destruction by spondylodiscites, you have and regularly we do it from anterior and XLF olive technique, and then address posterior to do the decompression of the epidural abscess. But here I choose to do it all from posterior with the same cage or a big cage, but from posterior. And then at the end, I'd like to talk about what's the role of UBA in revision of previous fusion surgery. When we have a previous TLIF operation, the unilateral biportal endoscopy, like here in L5S1, for 2 years TLIF operation, as a patient have L5 radiculopathy by wrist, or that had by foraminal and extraforaminal stenosis. And as we see here from this curved osteotome, without taking the rod, without removing the rod, we can go and do the decompression as we see in this video, and we can use around the corner, around the rod, do the decompression, doing neurolysis for the nerve roots. And if necessary to remove the rods, we can do it also endoscopically. Thank you so much for your attention. So it was an overview for me talking about what we can do with endoscope in fusion surgery.
Thank you very much, Dr. Abohussein.
Thank you very much, Dr. Raed, for your presentation. Nice. And as you can see, he's really stretching the envelopes in fusion, doing all kinds of fusion techniques already. Any questions from the other presenters? Professor Kwon, Javier to Raed, and vice versa?
If not, in the meantime, there's a few questions in the audience, definitely. So, yeah. Question about the time. How much time does it take, one hand, single level, UBE TLIF versus the first cases that you did? Dr. Abohussein.
Yeah. UBE TLIF, as a first case, as I started, talks about 3 to 3.5 hours for one level with UBE TLIF, but now it takes about 90 minutes.
Okay, with the thorough disc prep that you've shown and everything, so.
And what I say is a monoportal technique, endolift technique over the wire technique is a fast technique. So when you have an old patient, multi-morph patient, and when you don't need to do facetectomy or correction of big deformity, the monoportal technique gives you the chance to do it in 45 minutes.
Beautiful.
Good. Maybe a question for Dr. Quillo, back to the approach and the muscle destruction. So there was a question for stenosis cases, the advantage of biportal versus the tubular access. How do you see this?
Yes. Well, statistically, there is no advantage after 1 year of follow-up because the patients are equally. You can, with the tubular micro, you can obtain enlargement of the dural sac, and the outcomes is good in between two techniques. However, the short outcomes are better in biportal endoscopy because the patient requires less consume of opioids or analgesics, shorter hospital stay length, and obviously the BASIS course, the ODI scores in the short period, are better compared to microsurgery.
So less destructive, definitely also shown by the literature.
Yeah.
Professor Kwon, a question for you to the sides that we're operating on, left side versus right side. Maybe you can elaborate a little bit on the challenges being right-handed or left-handed, as in your case, I believe.
Yes, I think Dr. Javier has also already mentioned the difference of doing a biportal procedure on the left side and the right side. For a right-handed surgeon, you definitely should start with the left side because ergonomically it's much easier to drill and work on with your right hand on the left side surgery. And when you move on to the right side surgery, if you're holding the camera on the left side and your instruments on the right side, it inevitably gives you a larger chance of needing a larger laminotomy on the right side. So in that case, if you put your starting incisions a little bit caudally than the left side, it makes you easier to get through the interlaminar window. But definitely it's a little bit more challenging than the left side.
Yeah, thank you. So another question that you can answer all together if you like. So there's Heng Lim saying many older patients have central and extraforaminal stenosis at the same level. UBE can do interlaminar and transforaminal approach at the same sitting. Can Uniportal do the same?
Yeah, of course, but depending on the plan and depending on the patient, because if you want to perform a decompression of the subarticular and foraminal area and central area, the contralateral sublaminar approach in their biportal endoscopy is a very good option because you cross the midline, You don't need to observe the ipsilateral neural elements. You are working over the top, and then you can find very easy the tip of SIP medially, and then decompress and release the foraminal area. Since this is also called ISELF, which is also used in uniportal endoscopy, the interlaminar contralateral endoscopic lumbar foraminotomy. So it's just the trajectory. Spinal endoscopy is just think trajectories and then be very precise and accurate with this trajectory. But yes, it's possible.
Yeah. Thank you. I believe this already answers another question asking if it is possible to plan left side approach for a right side pathology. What else do we have? Let me quickly scan the questions. There is another one. Comparatively, our elderly patients do better with UBE compared to your conventional surgery. However, such advantage is not manifested in those below 70. With UBE, elderly patients have less blood loss, earlier mobilization, and less pain and less pneumonia. Does the panel have similar findings as well? My conclusion is the benefit among elderly is more pronounced compared to those below 70 years old. Thank you very much for this question. And what is your opinion on this?
Any from the faculty who wants to answer that? Professor Kwon, you want to answer it?
Yeah, sure. I 100% agree with that idea. It's not only about lumbar surgeries, but also with every different surgeries. The earlier you ambulate the patient, the earlier you put the patient back to normal daily activity, you have a lower chance of getting morbidities related to the surgery. So I definitely agree with it. And I always mobilize my patients on the same day or at least the next day after surgery. And in terms of endoscopic surgery, it's the perfect option we have to do that.
Yeah.
I'd like to add something. And this is an opportunity what we have to do under local anesthesia with endoscopic surgery, either monoportal or biportal. It's a very big advantage also, we should mention it, especially for elderly patients.
Mm-hmm. Good. So another question regarding foraminal stenosis, endoscopic lumbar foraminotomy versus fusion, endoscopic fusion, UBE fusion, maybe even, or monoportal fusion. What is your preference and why?
Whenever, could I answer it? Or?
Yeah, please.
Whenever we can save the patient from fusion, we will do it. When we see the patient had only foraminal stenosis, or we can do it with monoportal, very good. Even in cases of foraminal stenosis or the extraforaminal stenosis at L5S1 with high iliac crest, we can do it without fusion, for example, with biportal technique. So whenever we can save a patient and do less, how we can say it, less, if possible, we do it less if possible with only foraminotomy or decompression.
Absolutely. And following up with another question to you from Colombia, if it's possible to put a cage in a patient with a history of spondylotic syndrome.
Spondylotic syndrome, what means that's an spondylitic listhesis. I have many cases with more than 2 years now with till grade 2 spondylitic spondylolisthesis and those very good results. It's a matter of release. It's a matter of release. And as I show in my video, you can do a good release. You can go safely inside the disc space under direct vision.
And I believe you showed this one cage with the discitis,
yeah.
So the spondylodiscitis. What about this? You also do it?
Yes, and discitis also I do it endoscopically, because all of you us know the best solution of pollution is dilution. So irrigation help a lot, and it's really less traumatic.
Especially for these, you think the endoscopic approach is advantageous over mini open or without irrigation?
Yes.
Because also of the irrigation, you get out all the...
And not only to put a very large cage, we just an olive cage or an X-lift cage, I have never seen a case like this done with an open surgery or minimal invasive surgery from posterior, to the best of my knowledge.
So you want the large footprint, the irrigation, and then
Yes.
get it safe, yeah. So which approach do you recommend to start with for the endoscopic fusion?
I recommend to start with over-the-wire technique, endolift technique, because it's when you start to do transforaminal, monoportal transforaminal, you can, when you do it, you can start to do fusion using over-the-wire technique. Every technique, I would say, every technique has some tips and tricks, and you should learn how to do it in the right way, so you would have the best results. That's
good.
In terms of time, we have a few questions left, which we would like to answer.
Maybe we go to this one here. What is your experience of combining both foraminotomy and ULBD to tackle both foraminal, central, and lateral recess stenosis without a fusion? Are the long-term outcomes better than fusion?
I think endoscopy, the full spectrum of endoscopy is very, very highly accurate technique. So the first step before starting with endoscopy is to identify the pain generator or the compressor generator, the true generator of the pathology in your case, because endoscopy requires to be addressed to this specifically pathology. So that's the reason that with endoscopy, we decrease the damage around the tissues, because you don't need to observe everything. You don't need to find out what's happening in the superior or inferior level. That's the planning. The planning before the endoscopy is the most important thing. And then obviously acquire the skill set to perform endoscopy, uni or biportal endoscopy. But that's the reason that there's a lot of questions regarding if you can decompress the foraminal area and the subarticular area and the central area at the same time. Yeah, you can if your patient requires that. But if your patient only requires a very specific decompression, yeah, endoscopy is a good option to achieve this.
Yeah.
So people are very interested in the fusion side of things. So greetings to Portugal, Miguel Loureiro. Nice to see you here as well.
Yeah.
Here's a question for Raed Abohussein also regarding the posterior olive. So besides infection, do you use it in another indication? And if yes, which?
So I'd like to greet my friend Miguel Loureiro and our faculty in ESPINEA Academy. Thank you for your question and that you are here today. For me, I'd like to use it when I need to have a big footprint. So it's not only for infection cases, but also when I see in the MRT or in CT that I have a good corridor between the traversing and exiting nerve, so that I could put an 18-millimeter cage. So I do fascicectomy and morpholum laminectomy ipsilateral to have the chance to put the cage safely under direct vision, not only in infection cases.
And following up, how do you plan the incisions for this approach?
Or do you do another incision? There was a question also on the olive. Do you do another incision?
Yes, I do another incision. Actually, 15 minutes for talking about different techniques of endoscopic fusion is not fair enough. I talked this with Wolfgang many times. We need to have special courses for fusion.
We need to have a special webinar just on fusions. We just wanted to stretch it a little bit, to cover it a little bit, and as an outlook of what's possible and what's going on. And it's great to have such a good feedback and great interest in it.
Yeah.
Okay.
Thank you. Maybe then a quick question back to Professor Kwon regarding uniportal versus biportal in case of central and bilateral foraminal stenosis. What is your choice?
Central and bilateral, I think that would be maybe one of the rare indications that require fusion, probably. Another thing is maybe you can just approach with two different approaches, maybe do a interlaminar VLBD plus a transforaminal from another side. But I think I totally agree with the other two speakers today that it is really about modifying and making a precise way to deal things. If you just target it right, you can just achieve whatever you needed with this modification and add-on of these existing techniques.
Yeah,
great. Before we end up, and this kind of question is always coming up, we as a company and academy and ESPINEA will stand up and also try to cover what, if any complication is coming, and how do you manage it. We always train it, we always talk about it openly, very openly. That I think it's very important. And the question here also came up, how do you deal with dural lesions? Of course, and we have that, like in open surgery, you have it also in endoscopic, but they're very well manageable. Comments on your side? Comments on your side?
I start with my experience. Rarely we need to knit or to stitch to knot the dural region. It's enough to put Tacozil or dural patch whenever it's smaller than 1 centimeter. But the first thing to do is to go down with your water pressure. So you should take care to go down with your water pressure, use a good water pump, and then you put the Tacozil. The fact that we have intact muscles, it protects from the dural leak after the operation. But with monoportal and post-monoportal biportal, when you have a good experience, you can knot it, you can stitch it, you can knot it also. But it's really that you need to do this.
Similar comments, Javier? Or...
The first step is to avoid them. Avoid them.
Of course.
So,
but if it happens, it can be.
But if you have a dural tear, first of all, 1.2% of incidence of dural tears in biportal endoscopy compared with 0.8 in transforaminal or interlaminar, but together 3.2%. So there is no a big deal regarding dural tears in endoscopy. So 10% in open surgery. So there is no a big deal. But the thing is, as Raed said, dural patch, it's enough for most of the cases. But obviously, if you have the skills to sutures and close directly in an irregular dural tear with herniated roots through the dural tear, obviously, you can perform this direct closure of the dural tear and avoiding a conversion of the surgery. If you are not able to do that, convert the surgery and do the similar things that as a spinal surgeon do it. Just that. It's not a big deal, I think.
Same comment from your side. Yeah.
Just a small comment. What I usually do is I see if the arachnoid is injured and you actually see the CSF coming out. If it's a local anesthesia, I would just ask the patient to cough, and you will see if the CSF is coming out or not. You turn off the irrigation for a second, ask the patient to cough. If it's general anesthesia, you ask the anesthesiologist to do a Valsalva maneuver. If you see the CSF coming out, it means that the arachnoid is also injured. In that case, I prefer to do a suture, even endoscopically or open. But if you don't see the CSF coming out, it means that the arachnoid membrane is intact, and just putting a patch on would be enough for most of those cases.
Great. I think in a matter of time, we are at the end of this webinar. We had a lot of interesting questions, and the audience stayed on until now. Even we are over time, 25 minutes already. We still have 150 online. That's great. Interest is here, as you can see, and it's great to listen to the 3 faculty members. Always a pleasure to listen to you. We thank the whole audience for your interest, and we will be back again. Watch out what we are announcing and what is coming. We just wanted to show also, we have just published the last session, the last section again, the last edition of our most important scientific studies. More than 200 are included here on all kinds of subjects, on all kinds of indications. We do this every year. It's coming out, and anybody who is participating in our workshop can have a hands-on on it and can get it. And lots of material on endoscopic spine surgery published, but also more important for you and for everybody is hands-on. workshops and practice and train. We look forward to see you in one of our courses, okay, and one of the meetings. And thanks again to the audience, okay?
Thank you to all those enriching presentations, and see you soon, hopefully.
And hopefully see you soon, okay? Thanks, gentlemen. Thanks, everybody. Bye-bye.
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 Bye-bye.